So I think we are all striving to get perfect functional anatomy with our ACL reconstructions, and we want to look at selection of graft positioning, and fixation seems to be an important aspect in this whole cascade of ACL reconstruction. When we look at fixation, we want to know exactly the time to healing, and if you're looking at different healing options, the bone-to-bone healing occurs as early as 6 to 8 weeks, and as we progress, allografts are probably the ones that heal take the longest time to heal, so you need to have your fixation option to stand for that longer time. Also, now we are moving into the era of accelerated rehabilitation, and if we are doing that, we also need to make sure that our fixation devices can withstand the stresses that are being put forth on the graft by doing an accelerated rehab program. So I think we also need to realize two more factors. We need to realize what is the load to failure of the graft, which is different with different grafts, and we also need to realize what is the ultimate load to failure of the fixation device, which is a lot less than that of the failure of the graft. What that essentially means is that in the early healing phase, your fixation device is more likely to fail than your graft, which is why you require a strong fixation device. Also, what is important is that your graft is subjected to different kind of stresses. You have, which is the bungee cord effect, which is basically nothing but the graft moving up and down within the socket. You have a windscreen wiper effect, in which the graft moves horizontally in this manner, and lastly you have the elongation effect, in which the graft has some form of creep that occurs in it and then may cause problems with graft motion. Also, what we know from basic sciences is that if there is more than 3 millimeters motion within the tunnel, then you're likely to have problems with incorporation, because your fixation is not solid and there is problems of biological and mechanical integration of the graft within the tunnel. So these problems are more with non-aperture fixations, and we need to take them into consideration before we go ahead and decide which fixation device. If you look at the biomechanics of fixation, we talk about three aspects: the strength, the stiffness and slippage, and what we have is that we need something which is strong enough, stiff enough and secure enough to avoid all these three particular problems. There is no doubt that the ideal graft fixation should allow anatomic fixation. It should be biocompatible, safe, reproducible in everyone's hands. Of course, it should be MRI compatible, because we like to go back and see if there's something going wrong, and if we need a revision, it should be an easy revision without much of problems. The fixation devices broadly are categorized into two parts. We have the aperture fixation, where the fixation is done at the mouth of the tunnel, and we have the suspensory fixation, which is away from the mouth of the tunnel, and this can either be cortical, something like an endobutyl or a staple or a screw, or it can be cancellous within the substance of the cancellous bone, which are the various transfixation pins. So I think the world is divided between three religions. We have suspenders, we have screwers, and we have cross pinners, and that is where fixation is as of today. If you look at the interference screw, I think that has been by far the most widely practiced fixation device. So what do we mean by interference? It's basically the amount by which the diameter of the screw exceeds the gap between the graft and the tunnel. So if this is a screw that we put into a graft, the amount by which the diameter is going to exceed the gap between the graft and the tunnel actually is what is called as your interference. So if this is a hole and this is your graft, and this is the gap between the graft and the tunnel, and you put a screw in which is like this, then this much is going to be what is called as your interference fit, and that is the biomechanical definition of an interference fit. Aperture fixation has various advantages. It is going to give rise to minimal graft tunnel motion, which is very important. It is going to give rise to less femoral more than tibial tunnel widening, and the graft is going to have less creep. There are various factors which are going to influence your screw motion, and I think it's very nice to read this paper that came out of Andrew Amos's group in 2006. So the length, the size, the geometry, the divergence of the screw, the torque of insertion, the bone mineral density, and the screw material are all various important factors which influence interference screw fixation. So we'll just go quickly one by one and see what they are. So longer the length or longer the area of fixation, better is going to be your fixation. In a BTB graft, you really don't need to go all the way to engage the soft tissue. Even if you engage the bone plug, that is enough. What about the size of the screw? In a soft tissue graft, what is recommended is that it should be 1 millimeter larger than the diameter. With a BTB graft, since the tissue inside is quite hard and stiff, you can have a screw which is less than or equal to the same diameter of the tunnel. What about the geometry? If you have a soft thread kind of a configuration, it's going to be very reliable for soft tissue fixation, and there's a lot of evidence to show that you should have a reverse thread screw, especially if you're using it on the right knee. What about insertion torque? We know very well that if we have higher resistance, we have better fixation. Metal screws give better fixation. A larger diameter screw will give better fixation, and if you impact bone within the tunnel by doing serial dilatation, that will also give rise to better fixation. About divergence, we know is that if the divergence is increasing more than 20 degrees, it is going to compromise the stability of your fixation and lead to problems as well. As you move towards softer bones, and when the bone mineral density falls below 0.6 grams per square centimeter, the pull-out strength decreases, which is why in osteoporotic individuals, especially in the tibia, we need to probably look at using hybrid fixation techniques or double fixation techniques, because the bone in the tibia is more soft. What about materials? We have a variety of materials, but we know very well that metal screws probably are the best. We have a variety of biodegradable screws. The crystalline polylactides are probably better because they resorb late, but they have an advantage in which that they are MRI compatible, and if you are doing a revision, then you can sort of drill through them quite easily. Screw breakage is a problem with bio screws, and these are the old generation screws in which they were quite soft, and through various literature studies it has been recommended that you should avoid trying using screws which are less than 7 millimeters, especially on the femoral side. Bio screws could also have problems with tissue reactions, effusions, and tunnel widening with the previous designs. So this meta-analysis that was published in the Journal of Arthroscopy does say that tunnel widening is more significant in bio screws than metal screws, especially on the femoral side, and they recommend that we should not be using biodegradable screws on the femoral side, which is a definite no-no when you're looking at ACL fixation. Tissue reaction can also occur. This is one of my own patients, and I had to just go in and take out the screw and curate out the entire tunnel, this is absolutely a sterile inflammatory response to these particular screws. When looking at metal screws, we should choose titanium over stainless steel, because titanium screws can be covered by bone, and stainless steel screws should not be used because they get covered by fibrous tissue, which is something that we do not desire. What about cortical suspensory fixation? Cortical suspensory fixation is a very attractive choice, but it has some problems of increased graft tunnel motion, which is supposed to give rise to theoretical widening, but clinical studies that have been carried out do not actually show any difference in outcomes whether you use a suspensory device or not. The cancellous suspensory fixation devices cross the graft in the cancellous bone, but they have not lended themselves that well to the anatomic or the transportal method of fixation, and hence it is a technology, or it is a device that is almost extinct as of now. The cortical suspensory devices are the first generation devices in which you had a fixed loop and you had to make an insertional tunnel and a connection tunnel, and now we also have the second generation devices in which one can actually adjust the length of the loop once you flipped the device on the cortex of the femur. There are some papers which have come off in the last year, which have shown or which have compared these adjustable loop devices and fixed length devices. Of course, these studies were absolutely non-biased studies, and they did show that the adjustable loop devices fail faster than the fixed length devices, and they actually lengthened over a period of time. So if you had the adjustable loop device, after about 4,500 cycles, it lengthened far more than the fixed loop device, which probably may be some food for thought for us to decide whether we want to use a fixed or an adjustable loop devices. So this is some data that has come out from last year, and we sort of look at what we need to do about this in years to come. So if you look at the fixation options, on the femoral side, you could either have a bone plug or a soft tissue, and on the tibial side, you could have a bone plug or a soft tissue fixation. So on the femoral bone plug side, I think the aperture fixation with the help of interference screws is the gold standard. One can also use cortical suspension or cancellous suspension devices, but screws are the gold standard. If you're looking at soft tissue fixation, I think we should not be using aperture fixation. The preferred fixation would be some form of a cortical suspensory device. If you're going to be using a bioscrew alone on the femoral side, we have to be very careful with the rehab. On the tibial side, you can either go in with aperture fixation or hybrid fixation with the help of fixation posts. If you're looking at soft tissue fixation, you can either use a fixation device which is away in the form of a staple or a double staple, or go ahead and fix it with a standard interference screw. So these are the various options that we have for fixation both on the femur and the tibia, and I think basically it is what works best in your hands is what we want to do. So I think to conclude, I will say that fixation is very important in the early post-op period, because fixation is the weakest link. If the tibial fixation is at the maximum risk of failure because the bone is soft within the tibia, the clinical outcomes of various devices are comparable. Tunnel widening is a concern, especially with bioscrews. Aperture fixation is biomechanically more stable. Interference screws are the gold standard. Titanium screws are better than bio or stainless steel screws. If you do tunnel dilatation rather than drilling, it is going to improve the quality of fixation, and if there's any doubt, do not hesitate to add on hybrid fixation. Thank you.
Thank you, Dr. Sachin. That